break. Okay, so inshallah we're going to resume afterwards. So today's case is going to be what Dr. Abdullah calls as the medical student's worst nightmare. So, bas inshallah, with his guidance and Dr. Ali Shidi's guidance and our discussants, we're going to pull through. So, without any further ado, please, our panelists, please introduce yourselves, and then Dr. Abdullah, you can start. Okay, so introduce yourselves, please. Dr. Abdullah, our discussants, Khalid and Maryam, I guess.
Yeah. I am Dr. Abdullah. I am PGY2 in Internal Medicine program at SKMC. And I'll be the one who's presenting the case and discussing the most important clinical aspects of it.
Hi, my name is Khalid, and I'm a fifth-year medical student, and inshallah I'll be one of the discussants today.
Assalamu alaikum, I'm Maryam Fayasi. I'll be one of the discussants as well.
Okay, so let's start with the case. So we have a 54 years old male who presented with cough. So that's the chief complaint, cough for 5 days. So can you please what questions would you like to ask in the history? Khalid or Maryam, one of you.
Okay, so when did the cough start?
So it was 5 days ago.
Okay. Was there sputum?
The cough is dry.
Or was it dry cough?
Dry. So what further questions do you like?
What's the nature of the cough? This is dry cough. Is it like a barking cough, or is it different in any way to any cough he's had before?
No, it's the same type of cough. Usually, you don't patients don't notice that the cough is barking. That's most commonly happens in pediatric age group due to croup and parainfluenza virus. But now, like in adults, you don't really appreciate like a different character of cough. You need to ask if the cough has a specific pattern during the day. So is it more at night or more in the morning, more spread throughout the day? So those questions are important, because cough in the night mostly is going to be like you'll think more of asthma, which can present, variants of asthma can give you cough during the night. So this patient, his cough was throughout the day, and you need to ask about what associated symptoms. So what symptoms you would like to ask?
Does he have any shortness of breath?
Yeah, he does have shortness of breath, which is occasional, and after he coughs a lot, he feels short of breath. What would you like to ask more?
What about fever?
Yeah, he does have fever, but it's only subjective. He did not measure it. So you have fever.
Does he have any nausea or vomiting?
He vomited one time. He feels nauseated and has poor appetite.
And what about diarrhea?
No diarrhea and no constipation. So you have fever, cough, and shortness of breath. So what more questions you would like to ask regarding that?
So when did he start noticing the fever?
Like with the cough, the fever started. So now you have a differential. Okay, so what are you thinking? Which diagnosis are you gonna, like, most likely is gonna be the case? the patient diagnosis, what do you think this might be? When someone tell you I have cough and shortness of breath and fever, what would you think? Like
Could
the
it
most
be
important?
pneumonia or
Yeah, so you think of
influenza.
pneumonia. You think of infectious process, right? So you need to ask about more of infectious process to guide you which organism is it. So what questions you would like to ask regarding
has
infectious
he been
processes?
has he been in contact with any sick person?
Yeah, so sick contact, he doesn't have any sick contact.
What about smoking?
Okay, we'll come to that in the social history, but he is a smoker. We'll talk about that in the social history. But in the HPI, he has. You need to ask about recent travel history as well. You need to ask about travel history because, like in the beginning of COVID, whenever a patient came had a travel history to China, we thought of COVID. So you need to ask about travel history because certain organisms are more in certain places. So that's pretty much it in the past medical history. What about regarding after the past medical history, you're gonna go with review of system. You need to include things that are that can come with pneumonia-like picture. So you think of inflammatory diseases such as rheumatoid arthritis, lupus, systematic lupus erythematosus, autoimmune disease in general, because they come with acute flare, which can present like pneumonia. So you need to ask about joint pain, rash, night sweats, if they have any history of renal disease. You need to ask about those as well. Okay. So past medical history, the patient is only he only has dyslipidemia, and he's on statin, atorvastatin. Family history is negative. Social history, what things you need to ask about the social history? You need to ask about smoking and alcohol. So yeah, so he's an occasional smoker. Like he smokes only 1 pack per year. So he's not like a heavy smoker. Okay, so he only smokes occasionally. Khalid,
Is his dyslipidemia controlled or?
his dyslipidemia, it is controlled. He's following up for that, but you don't have any like numbers or anything. Yeah, you don't have any. He doesn't know how much is the LDL, how much is the other lipid panels. But you need also to ask about alcohol. So he's non-alcoholic. Why you need to ask about alcohol? So if a patient who's alcoholic came with pneumonia, what is the most likely organism?
Klebsiella.
Exactly. So in the exams, the most common organism is Klebsiella. In real life, strep pneumonia. Okay, strep pneumonia always the most common organism in everyone, every disease. But more organisms affect patients. Klebsiella affect patients who are alcoholic more. Okay, so that's pretty much the history. We're gonna go back to the history because there are few things you need to ask more. But let's go to the examination and the labs first. Then we will go back to the history. So examination. He only dyslipidemic in the past medical history. So in vitally, the patient is vitally stable. His temperature is 38. His respiratory rate is a bit high, 32. Heart rate is 120. Blood pressure is 134/83. Oxygen saturation is 84 in room A. So, okay, guys, you see those vitals. What other things do you need to do? Like, this is the vitals. And when you see this, what you need to do first?
Generally inspect him Then try to go for focused respiratory exam.
Yeah, but before
Or
you do that, you're gonna put the
Mhm.
patient on.
Oxygen.
Yeah, and you need to make sure that the patient is stable, which means the patient, like if the patient is suffocating in front of you, you're not gonna do examination. You're gonna call the ICU. You need, this patient is sick. He needs maybe intubation. So you need to make sure that whenever you have abnormal vitals, you need to make sure that the patient has intact airways, his he is on oxygen, and he has in terms of blood pressure, the blood pressure is okay, is not low. Okay, so you need to make sure of those three things, the ABC. Okay, so general examination. What are you gonna look for in general examination, Mariam?
I look for volume status. So
Okay,
like skin turgor,
okay.
like the sunken eyes, maybe the mucous membranes.
Okay, so before you do that, you're gonna see the patient from the edge of the bed. See him if he's tachypneic, he's stable, he's comfortable, he's in pain. So this patient, clearly from the respiratory rate, he's tachypneic. Now, the other things, skin turgor, sunken eyes, those signs are inspecific and invaluable in adults, because adults, like if you have a 70 years old man who's bedbound, the skin is wrinkling, maybe he has sunken eye, maybe he's cachectic, that doesn't tell you that the patient is dehydrated or not. So those signs are usually used in peds or pediatric age group, but in adults you cannot use them.
He's not severely dehydrated. We can look from the vitals.
Yeah,
but his heart rate is increased.
Yeah, heart rate is increased, but that can be also from pneumonia. So what things you can do, and usually in adults, to look for volume status. So there is one specific thing you can do, so you can know that the patient is dehydrated.
Urine output.
Urine output. That's one thing. What is the other thing? Like a physical exam, something related to change in position.
Postural hypertension.
Yes, orthostatic hypotension. So you measure the cuff on one position, for example, sitting, and then after 3 minutes, you're gonna measure the blood pressure, and then you make the patient stand, and then after 3 minutes, you measure the blood pressure. You don't do it after 1 minute. You don't do it after 2 minutes. After 3 minutes, you need to say this specifically to the nurses, because the nurses sometimes, some of them, they don't know. So they measure it exactly after change of immediately after changing of position, which can give you false readings. Okay, so after 3 minutes. So orthostatic hypotension is specific, and it's a valuable tool to measure volume status in adults. Okay, like to know if the patient is dehydrated. But obviously you cannot do it in patients who are very old, who are bedbound and other things. So it's limited. It has its own limitations. So in this patient, the orthostatic hypotension was not there. So the blood pressure was maintaining with change of position. Okay, so that's the general examination. What are you going? You're gonna look. What are you gonna examine next? Khalid, Mariam.
I'm gonna do something for respiratory. So like I wanna auscultate, see, make sure the air entry is equal bilaterally, and listen for any crackles.
Yeah, so the patient has bilateral crackles in respiratory examination. You need to do also the other things, the tactile parameters, the chest expansion. But the most important thing is you do those things, the tactile parameters, the percussion, the The chest expansion is more useful in patients with pleural effusion or pneumothorax, but in general pneumonia, it's not really useful, okay? Because it doesn't tell you anything. If you have a unilateral crackles or unilateral signs, then you do the other things to know if there's an effusion, if it's only pneumonia, if it's pneumothorax. But in bilateral, like if you have bilateral added sounds, that is not very useful. So this patient has crackles. What about the cardiovascular exam? Was normal in this patient? In the cardiovascular exam, don't forget to do a lower limb edema, because you need to do that in all patients. Every single patient, you look for edema. Okay, so this patient was not edematous. So that's the most important examination you're gonna do. Now you look for the investigations. And what investigations are you gonna do to this patient?
We need a chest X-ray.
Okay,
and
but
we need CBC.
Yeah, so whenever someone tells you what investigations they're gonna do for a patient, you're gonna start with the blood, then you go for the radiology. That's the way to present the investigations, but that's not always the way we do it in the clinical setting. Okay, so you can get a chest X-ray before doing the bloods in clinical setting. We have a portable chest X-ray. Takes only 2-3 minutes, but the bloods take an hour. So when you present, you start with the labs, the blood investigation. So what blood investigations are gonna do, Khalid?
CBC, electrolytes.
Okay, CBC and electrolytes. What else?
His
So
serum osmolality, for example.
No, you're not gonna do that for everyone. So you're just gonna do CBC and electrolytes, okay? Then you go for what do you call it? Then you go for radiological investigations. You're gonna do a chest X-ray, and also because this patient is tachypneic, you're gonna do an ABG, arterial blood gas. Okay, and you're gonna do an ECG. So usually in patients who are tachypneic, you need to do 5 things: CBC, electrolytes, chest X-ray, ECG, and ABG. So those 5 things you need to do in every patient who is tachypneic. Okay, so you did the ECG. The ECG is sinus rhythm, tachycardia, sinus tachycardia. You did the ABG. The ABG showed only hypoxemia, low PO2, but the PCO2 is normal. You did the other labs, the CBC and the electrolytes, and I'm gonna give you the results now. So the sodium, the electrolytes, is 119. The potassium is 4.1. The urea is 7. Creatinine is 100. The hemoglobin is 130. WB count is 18,000. Platelets 510. So you have those results. Now, Mariam, you have the results. You have the results of the CBC. Let's go for the chest X-ray as well. Then we discuss them all together. So can we look at the chest X-ray as well? Okay. So Mariam, you have this chest X-ray. So what does the chest X-ray tell you? What do you see in that X-ray?
So there isn't like one specific consolidation. There's in the midline, like diffuse.
Yeah. So it's what you call it bilateral infiltrates. Okay. So those this sign is in a setting of pneumonia. You call this which type of pneumonia? It has a specific term. What do you call it?
Interstitial.
Yeah, interstitial pneumonia, or bronchoalveolar pneumonia, or atypical pneumonia. So those are the signs you see in the X-ray. Okay, it's not a patch. It's not a consolidation somewhere. It's diffused. Okay, but be careful. This sign, this chest X-ray can be there in all interstitial lung disease as well. Okay, so this is the chest X-ray. Now you have the blood. Let's go back to the CBC if you don't mind. Okay, so this is the labs. Okay, now what? And other investigations, other history, like you have the patient, other history points you're gonna go and ask, and other physical examinations you're gonna do in setting of those counts and those labs.
Okay, so the sodium is very low. It's very alarming. I would see if the patient is alert and conscious.
Yes, exactly.
Or if he's confused.
So the patient is conscious and alert because he give you all the history. Okay. What other specific things you're gonna ask regarding sodium?
Has he had any procedures recently?
Why do you ask that?
Because some procedures they use dilute fluids, such as, like, for example, the prostate TURP in males, and in females gynecological procedures.
صح. Yeah, that's an important question, but he did not have any recent surgeries. When you ask what else, what symptoms you want to ask about in hyponatremia? So what are the most
does he have
important
confusion?
Symptoms? No, he's not confused.
Delirium?
He's not delirious.
Did he have any muscle weakness?
Anything related to neurological symptoms. So you need to ask about confusion, muscle weakness. He's not weak. You need to ask about headache, because patients with hyponatremia present with headache. And you need to ask about seizures. Okay, so the most alarming things: seizures, confusion, coma. So those are alarming signs. But headache, nausea, vomiting, we call it mild symptoms of hyponatremia. So the patient had headache, okay, and from the history, you know that the patient was nauseated and had one episode of vomiting. Okay, now in the examination, what other system you would like to examine?
The creatinine is high, so that might be AKI.
Creatinine is the normal, the upper normal, upper level of normal. So it's not very high, but
so the potassium.
Oh, potassium is normal. Now, when the physical examination, you need to examine the neurological system as well, because in patients with hyponatremia, they have neurological signs as well. Okay, so the patient neurological examination was normal. So let's go now in the labs and how to manage hyponatremia. So this is hyponatremia. What next step? What other investigations you would like to request to know what is the cause of hyponatremia?
Can we check his blood glucose and lipids and protein?
Blood glucose is 9. You don't need to check for lipids and protein.
I would test for the osmolality and the volume.
Exactly. Which osmolarity of the serum or the urine?
Both.
Ideally both, yeah.
And urine sodium.
Okay, so let's begin with the blood. You're gonna check the osmolarity. The osmolarity was 254, which is low. So now you have the hyposmolar hyponatremia, and the urine osmolarity and sodium. Osmolarity of the urine is 300, which is high. Urine osmolarity, urine sodium is 30. Okay, so you have those results. Now tell me, what is your thinking process? What is the cause of hyponatremia, and how did you, or what next? How do you know the type of hyponatremia? What is the cause of hyponatremia in this case?
In hyposmol, it's more likely due to fluid loss, right? So vomiting, diarrhea, use of diuretics.
So you think this patient has hypovolemic hyponatremia? So how do you know if it's hypovolemic or iso?
No, sorry, I need to think about it because of the osmolarity.
Okay. So let's start with sodium. So when you have a low sodium, what's the first step you need to do? So have an algorithm in your mind. So the first thing you need to do is to measure the serum osmolarity. If the serum osmolarity is low, that means that it's really true hyponatremia. The sodium is low because of a disease or because of a process, and that sodium caused low serum osmolarity. So hypoosmolar hyponatremia, it's a really thing, something. It's a disease. It's some pathological process caused the hyponatremia. In hyperosmolar hyponatremia, that is commonly seen in patients with hyperglycemia. In isoosmolar hyponatremia, that's seen in patients with hyperlipidemia and high protein. So isoosmolar hyponatremia is not commonly seen because it's a lab error, and the labs are now more advanced. It's rare. You're not gonna see it. I never saw it. Patients with hyperosmolar hyponatremia, they need like a very large amount of hyperglycemia to cause this hyponatremia, okay? So in hypoosmolar hyponatremia, so you have a real hyponatremia to investigate. Now, how are you gonna approach hypoosmolar hyponatremia? So you look for the volume status. Now, it's really difficult. I never understood volume status. I'm never gonna understand volume status. So you need to work up with the labs to know the cause. So this patient, the first step in assessing volume status is look for hypervolemic signs, which are very easy to look for. Look for raised GVP, look for edema, look for ascites, look for fluid overload. So this patient has no fluid overload. So you ruled out hypervolemic hyponatremia. Okay, so what are the causes of hypervolemic hyponatremia?
It could include congestive heart failure, cirrhosis.
Congestive heart failure, cirrhosis.
Or
nephrotic
renal.
syndrome.
Nephrotic syndrome. So if you ruled out hypervolemic, خلاص يعني those are not the cause. Now, in patients with hypervolemic hyponatremia, you're gonna treat them with
Fluid
what
restriction?
is the treatment? No. You can't, yeah, fluid
Diuresis.
restriction is one, yeah, and your diuresis. That's the mainstay of treatment. So you're gonna diurese them. You're gonna give them which type of diuresis? Which type of
Loop
diuretics? Loop diuretics. Lasix, furosemide, okay? So you're gonna furosemide, and that is gonna resolve their hyponatremia. But isn't like loop diuretics cause hyponatremia? So how do you give them in patients who are hyponatremic?
I think there's a greater loss of fluid, so it will balance out.
Yeah.
Like,
exactly. صح. So in loop diuretics, you're gonna lose more fluids than sodium, and that would correct the hyponatremia. Now, after you ruled out hypervolemic, you have two things. Either the patient is hypovolemic or the patient is euvolemic. You're not going to differentiate between them in the clinical exam because there are no signs to indicate hypovolemia or normal volume status. You're going to differentiate between them from the labs. So let's look at the urine. Now, I need to go back to physiology a little bit, because if you understood the physiology, you're going to understand the whole thing of hyponatremia. So there are two systems associated with volume status and osmolarity. We have the ADH, which is antidiuretic hormone, and we have the RAS system. Renal and yeah. Okay. So what does renal angiotensin aldosterone do?
Retains sodium. So
yeah. So
sodium for water for sodium.
So this works in patients who are hypovolemic or in an abnormal volume status. Is going to affect the RAS system, and the RAS system will lower the sodium level in the blood, in the urine. I'm sorry. RAS system will lower the sodium levels in the urine. So if you have a urine sodium which is low, that means the RAS system is activated. Okay. What about ADH? So what does ADH do?
It retains the water.
Yes, and
without the salt.
And it's stimulated in which cases?
When there's a low volume.
Yeah, no, stimulated first in changes of osmolarity. So if you have hypernatremia, if it's the osmolarity of the blood is changed, the ADH is gonna work. But in cases of severe hypovolemia, the ADH will be secreted as well. So ADH is gonna concentrate the urine. So if you have a concentrated urine, that tells you that the ADH is activated. So the urine sodium tells you about the RAS, renal angiotensin aldosterone. The urine osmolarity is gonna tell you about the ADH. And from those two numbers, you're gonna work out which scenario the patient has or which disease. So
SIADH.
Let's give you an example. So in a patient who has a very concentrated urine, so urine osmolarity is high and the urine sodium is low, that is going to be more consistent with which scenario, which cases? Okay, so urine sodium is low, which means that the RAS system is activated, and the urine osmolarity is high, which means the ADH is activated. So high RAS and high ADH is gonna be there in which scenario?
Is it hypervolemic though? It's not.
Yeah,
it won't be
in hypovolemia, if you have severe volume loss, the RAS system is gonna be activated. Any volume changes, if you have hypovolemia, the RAS system is gonna be activated, and the ADH is gonna be activated. So you're gonna have a concentrated urine because the body wants to reabsorb more water, and you're gonna have low urine sodium because the RAS system is activated and it's reabsorbing more sodium to correct the fluid loss. Okay.
Does it happen with like diarrhea and burns?
Yeah. So that more be consistent with hypovolemia that is not caused by renal disease, or it's not related to renal issues. Okay. So in hypovolemia in general, you're gonna have high urine concentration and low urine sodium. If you have if the patient was taking diuretics, you're gonna have high concentrated urine and high urine sodium because he's losing sodium from the diuretics. And to to know that the patient has a hyponatremia from diuretics is easy. You look for the medications and you see they're using diuretics. Okay. Am I confusing you or?
No, you're not.
Okay.
We're just learning to do it in a more systematic way.
Yeah. Okay. So in patients, if you have a urine, if you have the urine osmolarity is very low, and the urine sodium is normal or normal to high. So what does that tell you?
That maybe the RAS is not working, so the kidney is not working properly.
The RAS is not. Always assume normal kidneys, okay? So don't think of any like in hyponatremia. To always assume normal kidneys, because if you thought of like abnormal kidneys, then that will confuse you even more. So this patient, if he has low urine osmolarity and normal urine sodium, that tells you that the RAS is not working, okay? It's not activated, and the ADH is low because you have low urine sodium, low urine osmolarity, I'm sorry. So which cases is going to give you low ADH? Those are the patients who are going to, remember, ADH is activated by the serum osmolarity. So if the patient drinks large quantities of water, then the ADH is not going to work because you have all disturbance in osmolarity. You don't need more water in the body. So the ADH is not going to work. So you have a very diluted urine. Okay. So those are the cases which Khalid mentioned post TURB and post. We call, there is a specific entity in patients who are very alcoholic. They call it beer.
Beer potonemia,
exactly. Okay. Now the last, I think the last thing, the last situation where you have a high urine osmolarity and very low urine sodium. I'm sorry, I'm confusing. High urine osmolarity and high urine sodium. So this is the case where you have ADH which is activated due to various reasons. We call that inappropriate ADH. So in cases of inappropriate ADH, the ADH gets secreted because of something, and that ADH is going to reabsorb more water from the kidney, which makes the urine diluted. And because you have high volume, the body tries to compensate. The RAS system is not going to be activated. You're going to lose sodium from the body. Through the kidney.
Isn't the urine concentrated versus dilute?
Yeah, concentrated. So the osmolarity is gonna be high. So in syndrome of inappropriate ADH release or high ADH, you're gonna have concentrated urine and you're gonna have high urine sodium. Am I everything is okay right now? Well, I confused. You feel like okay. Overwhelmed out. Okay. So what are the causes of SIADH?
It can present as a paraneoplastic syndrome.
Okay, so it can, anything, just remember this, anything that affects the CNS and the lungs can give you SIADH. So pneumonia, lung cancer, small cell carcinoma, brain cancers, brain pathology, I don't know, anything that affects the CNS, meningitis, they can give you SIADH, okay? Syndrome of inappropriate ADH. And other thing is antipsychotics and medications. Antipsychotic medications, they give you high ADH and they cause SIADH. And usually you're going to see them in psychiatric patients. So that's a typical exam question when you have a patient who is known to have bipolar, who presented with any specific symptoms. You did the lab and you saw hyponatremia. So how you are going to approach the case? You're going to look at the urine osmolarity. If the urine osmolarity is low, that means that the ADH is not released. That means that this patient is psychiatric, so probably he drank a lot of things, drank a lot of water. So maybe he's polydipsic, or he has something related to high water intake. So the answer is going to be polydipsia. He drank a lot of water. If the urine osmolarity was high, look at the urine sodium. If the urine sodium is high, that tells you that this is ADH release, inappropriate ADH release. So that is going to be caused by his medications. So you need to look at the medications and you need to change the medications. So that's pretty much hyponatremia. So now let's go for the treatment. The treatment is complicated. It's not very easy, but I'll just simplify it for you in a broad terms. So hypervolemic, you're gonna use diuretics, okay? In severe, in SIADH, you're gonna use what are you gonna treat SIADH with?
Is it vasopressin antagonists?
No, not the first line. The first line is
the Vaptans.
no, that's vasopressin
that's
antagonist. That's not the first line. The first line is gonna be fluid restriction, because you have more fluid in the blood. You have more water related to sodium in the blood, so you're gonna restrict them, and you treat the underlying cause. Okay, if that didn't work, you're gonna use sodium tablets. If that didn't work, then you go for Viptans. You are not gonna start any patient on Viptans. Okay, that's decision is multidisciplinary, mostly like taken by nephrologists, and it's really complicated, and it's not really approved. The only one Viptan is approved, and the use of it is not very very commonly used. Now, in regards to SIDH, you're gonna fluid restrict them. And hypovolemia, you're gonna give them normal saline. And patients who are taking a lot of water, so patients with beer pantimony, potonemia, patients who are primary polydipsia, you're gonna restrict them from water, and hyponatremia is gonna be resolving on its own. The last thing is in severe cases of hyponatremia. So how do we define severe hyponatremia?
If it's acute presentation.
Yeah, symptomatic. So any patient who is symptomatic, that automatically put them in a severe category. So severe, like I'm not talking about any symptoms such as like headache and nausea. I'm talking about severe symptoms, confusion, seizures. Those are severe symptoms. And in those cases, you're gonna replace the sodium quickly with hypertonic saline. Okay, so now hypertonic saline is 3% sodium, okay? Sodium chloride. Now, what's the issues about what you need to be worried about in using hypertonic saline?
Central pontine myelitis.
Yes, and can you explain that more, Khalid?
Sort of like when you give very high sodium intravascularly, the fluid will shift away from the neurons to the intravascular. So basically, a shrinking of the neurons.
Yeah. So in giving hypertonic saline, you need to give it slowly, and to monitor the urine sodium, you don't need to increase it suddenly too much, because that will cause more damage than good. But they usually say if patients have acute hyponatremia, then you can correct the sodium like immediately, rapidly. If the patient has chronic hyponatremia, then you need to increase it slowly. Now, in acute is defined any hyponatremia less than 2 days, less than 48 hours. Chronic is more than 48 hours. Now, you don't know, like you're never gonna see any patient who is acute unless the patient was in the hospital and you do daily electrolytes measurements. Otherwise, you cannot really know if this is acute or not, or chronic. So always consider every hyponatremia as chronic until proven otherwise. Okay, because if you treated it as acute and corrected the sodium rapidly, the patient is gonna have central protein myelolysis, and the patient is gonna be irreversibly like damaged, and then you caused more harm than good. So you need to correct the sodium slowly. Now, it doesn't matter for you. It's not like in your stage. You don't know. You don't have to know how much should I correct. What doses should I correct the sodium with? So you just need to know that you need to correct slowly. Okay. So that's basically hyponatremia. So in this patient, let's go back to the patient. So Mariam, based on what we discussed, now let's look at the labs and let's analyze systematically what is the type of hyponatremia, what is the cause of hyponatremia, and how are we going to treat it. Hello?
Yes.
Yeah.
Do I summarize the case or what?
No.
Exactly.
Just look at the labs and tell me which hyponatremia is it, and tell me what is the management. What is your plan? What is your management?
Okay, so the patient has hyponatremia.
Okay.
It's either euvolemic or hypovolemic. We can't tell.
Yeah. Before that, it's hypoosmolar hyponatremia.
Right.
Yeah.
So
and
it's
the
true
patient is not.
hyponatremia.
Yeah, the patient is not hypervolemic because there is no edema. Then go on, Maria.
And yes, and then so it's not severe because the patient does not present with any neurological symptoms like severe seizures or
صح.
any of that.
Okay. Yeah.
So we need to start with fluid resuscitation, basically.
No, wait. Let's tell me the cause of hyponatremia first. How do you know the cause of hyponatremia based on what we discussed and based on the labs? It's okay. Take your time and tell me.
Okay,
what do you think?
so okay.
Just tell us.
So there's
like
a low serum
process.
osmolality.
Okay.
Okay, so low serum osmolality.
Yeah.
And the urine, did you say that's high or low?
Yeah. The urine osmolarity is high, and the urine sodium is high.
Okay, so that means there's more fluid retention.
Yes.
Yeah, because
we said it's more
so
in
there's
line
more
with
ADH.
SIDH.
Exactly. Yes. What about the RAS system? Is it activated or not activated?
Not activated.
صح. And you know that
because the sodium is low.
The serum sodium, the urine sodium is high. If the urine sodium was low, then that means that the RAS is activated. So this, basically, what do we call this?
SIADH.
SIDH. Okay. And you're gonna treat it with what?
A fluid restriction.
Exactly. What about the pneumonia? You're gonna treat it with what?
Antibiotics.
Yeah. Okay. Which antibiotic?
So that covers strep pneumo, probably.
Okay, but that
Do we
patient,
need to
okay,
get the culture
so
first?
yeah, you're gonna send for cultures, but basically, يعني most cases of pneumonia, the cultures are negative. So in that case, you have an atypical pneumonia, so you're gonna cover atypicals. So
Okay.
you're gonna cover for strep, gram negatives, and you need to cover for atypicals as well. So definitely
Mycoplasma.
So
to cover the
yeah, so atypicals is covered by macrolides, okay? Macrolides. So you're gonna give macrolides, and you're gonna give something else with it. So you can go with ceftriaxone, you can give with amoxicillin, clavulanic acid, anything which has broad cover. So I personally choose augmentin, amoxicillin with clavulanic acid, okay? But you can choose whatever you want. There is no specific choice which is preferable than the other. So that's basically the case. So if you have any further questions, any further comments, Khalid, Mariam?
Thank you, doctor. It was all very clear. Interesting approach.
Yeah, okay, thank you. There is one more thing I'd like to say. So in the exam, a trick in the exam, if you saw a urine's osmolarity higher than the serum osmolarity, think SIADH, okay? That's 99% of the questions is going to be SIADH, okay? If you saw the urine
One more time,
osmolarity
doctor.
higher, if the urine osmolarity is higher than the serum osmolarity, that's most probably SIADH. And you need to look at the most common cause of SIADH is not cancer, it's medications. So you need to look for medications and to change the patient's medications. So that's basically the case. If the audience have any other questions, I'm more than happy to answer them.
We have one question from the audience. So what caused the SIADH in this patient?
Pneumonia. Atypical pneumonia. That's the
atypical pneumonia. Okay. Any other
or
questions
from
the... Any more questions from the floor? I think you guys did a great job. Honestly, I'm so impressed with our discussions today. I'm in my final year and I didn't know half the stuff that you guys knew, so congrats. Dr. Abdullah, thank you so much for this extensive approach. I think you really made it very clear. And if we don't have any more questions, and طبعا of course, unfortunately, Dr. Ali could not make it. He had some technical problems with every device he used, and inshallah next time we'll have the chance to discuss more cases with him. Thanks to our scribe, I think she did a great job covering everything. Oh, we do have another question. So if the patient presented with neurological symptoms, should we consider a tumor as the cause? I think.
Yeah.
Hind, is that what you mean?
Okay, so if the patient presented with neurological symptoms and then you saw that the patient's sodium is low, you think, okay, so that you attribute those neurological symptoms to the sodium, but then it's difficult to generalize it. It's mostly patient specific. So if a patient presented with a sudden onset of loss of weakness of the upper arm, and then he presented with very low sodium, I'm not gonna say that this is due to sodium. I'm gonna say this is most probably stroke. So I'm gonna treat the sodium and I'm gonna scan the patient to look for stroke. So that's basically it. So you need to look at the symptoms, you need to correct the sodium, and then you look at the symptoms. Do they go away with the sodium correction? And is there anything else that the patient might have? Okay, and usually everybody who has neurological symptoms, mostly they're gonna get a CT scan to rule out any other like intracranial pathology. Okay, because you need to look also for the cause of the hyponatremia. So what is the cause of the hyponatremia? If you have another cause, fine, but if you don't have any cause, that means that mostly be like neurologic causes, and the sodium is low because of SIADH.
Okay, Hind, I hope this answers your question. So any more questions before we close?
Can see. Thank you. Okay.
Okay. Okay, then. Thank you, everyone. And inshallah, we'll see you in further episodes. And again, thank you for our discussants and our presenter and our scribes. I can see we had 2 scribes today. So thank you so much. You guys did an amazing job. And we'll see you, inshallah. So take care, stay safe, and take the vaccine. Okay, guys.
Okay. Thank you.
Bye.
Bye.
Thank you, everyone.